Most commonly, we use olopatadine, clinical use. The uses of these drugs are there will be combined effect of the immediate effect of the antihistaminic effect and long-term effect of mast cell stabilization. The most commonly used drug in this category is olopatadine. And the other one is, next one is topical non-steroid anti-inflammatory drugs. In some allergic conditions, we can use these drugs also to treat the allergy. For example, flurbiprofen, ketorolac, bromfenac are available in the clinical practice also. Main use is it reduces the itching, and that means itching is the main symptom of the allergic condition, and inflammation of the conjunctiva and cornea. And we can also use suppose if some cases are resistant for these drugs also, then we go for weak corticosteroids. Why weak? Because the potent steroids will cause rise of, main side effect is rise of intraocular tension. That means they will cause primary open angle glaucoma. In 30% of the people using these corticosteroids topically, they may get open angle glaucomas. So we should use steroids cautiously while treating the allergic conjunctivitis. So we use only weak corticosteroids. That is also for topical use only. These weak corticosteroids mainly we use in the clinical practice are loteprednol, fluoromethalone, and remixolone. Most commonly we use loteprednol and fluoromethalone. Preparations are available from many pharmaceutical companies. The main use is to treat the severe allergic conjunctivitis. In children and young people, the allergic reactions are so severe. So we cannot control the allergic reaction by using these H1 receptor antagonists and mast cell stabilizers. So we put them on short-term steroid therapy for 1 week or 10 days like that. Only short-term, that too, we should use weak corticosteroids because these people receiving corticosteroid eye drops are more prone to get primary open-angle glaucomas. 30% of the people will get primary open-angle glaucoma. Suppose they are treated with steroids. So we should use steroids cautiously. And that too, because this allergic condition is seen in the children, that should be another caution because steroids are contraindicated in children. Long-term steroid usage is contraindicated. So we use only weak corticosteroids for short periods to treat the acute condition. And whenever the condition comes into control, then we can shift the drug into H1 receptor antagonists or both mast cell stabilizing and H1 receptor antagonists. And other one is oral antihistaminics also. These include cetirizine, levocetirizine, loratadine, desloratadine. These also can be used along with the topical preparations. And it can be used for treating systemic allergy symptoms also. Some people will have allergies, all allergies together, like allergic rhinitis, allergic bronchitis. They also get allergic conjunctivitis. So to treat all these conditions at the same time, we put the people on cetirizine and loratadine. In the ophthalmological practice also, along with the topical drugs, we put with oral antihistaminics like cetirizine and loratadine. And the last one is immunomodulator. This is the last resort. Suppose all these measures are failed, then only we should use, you should go for immunomodulators. So the patient is very severely suffering, then only we should use your immunomodulators. These include cyclosporin and tacrolimus. These are in the these topical preparations are available as an ointment form, and these are only used whenever all the above drugs are failed. That means there is no response to all the above drugs. Then only we should prescribe the immunomodulators. That means we should use these drugs in refractory cases, very resistant cases of allergic conjunctivitis. And the next one is the lubricating agents. These lubricating agents are very commonly used drugs because this is used to treat dry eye. So many people are coming with a complaint of burning sensation, dryness, grittiness, like that. So most of the ophthalmology patients are about 75% of the people will have this complaint, and depending upon age group also. Females more than 40 years and males also. So after getting into some age, there will be defective function of the meibomian glands. Lipid layer is secretion is defective, and the people are more prone to get dry eyes because there is excessive evaporation of the tears, so that it will cause dry eye. And those nowadays young people are also getting this dry problem due to continuous watching of the systems. Due to continuous watching of systems and laptops like that, cell phones like that, they will get the blinking rate will be decreased. So they are more prone to get dry eye. And this dry eye problem will lead to severe itching, irritation, grittiness, foreign body sensation, and watering. So to treat these conditions, we will give lubricating agents. We will prescribe lubricating agents. And what are the other causes of dry eye? In menopausal woman, postmenopausal woman, there will be defective secretion of the hormones, estrogen, progesterone. So there will be a defective secretion of the meibomian gland. These will cause again dry eye. And what other conditions? And people, those who are working outside, outside homes, like dry climates and dry and dusty climates, they will also more prone to get this dry symptom. For that also, we should give lubricating agents. And post-operatively also, some people may get dry eyes, and there are also some like inflammatory conditions of the lids, like meibominitis. In case of chronic meibominitis, there is defective secretion of the meibomian gland, leading to defective absence of the lipid layer in the tear film. There will be three components of the tear film. That is, one is aqueous layer, mucus layer, and aqueous layer is the innermost. Middle one is the mucus layer, and topmost is externally the lipid layer. This lipid layer will protect the lacrimal fluid to evaporate. Any defect in the secretion of these three components of the tear film will lead to dry eye. And in some conditions like ectropion, entropion, there will be defective closure of the globe. So due to defective closure of the globe, there will be more evaporation of the tears. That will lead to dry eye again. These are so many causes causing dry eyes. For all those conditions, we will prescribe lubricating agents, otherwise called artificial tears. Main commercially available artificial tears ingredients are: first is the base ingredient, that is balanced amount of electrolytes to maintain the ocular tonicity, that is saline solution, and buffers like boric acid and viscosity agents to enhance the viscosity and promote the film stability. That means it should be spread evenly all over the globe and permits proper coverage of the exposed area of the conjunctiva, and also preservatives like benzalkonium chloride and chlorobutanol. Mainly these preparations will contain the balanced amount of electrolytes to maintain the ocular tonicity, and buffering agents like boric acid, and viscosity agents like to enhance the viscosity and promote the tear film stability. and preservatives like benzalkonium chloride and chlorobutanol. And first one is a viscosity agent. The main viscosity agents available in the market are cellulose esters and polyvinyl alcohol-based solutions. In the group of cellulose esters, we have methyl cellulose, hydroxymethyl cellulose, carboxymethyl cellulose. There is number of preparations available in this category. Another one is polyvinyl alcohol-based solutions are polyvinyl alcohol and providine, polyvinyl pyrrolidine polymers. And increased viscosity agents are polycarbophil and dextran and hyaluronidase. The viscosity, to maintain the viscosity, they'll have polycarbophil, polycarbophil and dextran and hyaluronidase. The combination of cellulose and ester and polyvinyl pyrrolidine will be is available, and along with the white petroleum and lanolin. That is the base for the lubricant drops. Next, other one is available topical preparations for this to treat the dry condition are eye drops in the form of eye drops, gels, lubricating ointments, and slow release ocular inserts. First one is most commonly we prescribe eye drops and lubricating gels. For severe cases, we can give lubricating gels because eye drops, the effect will be short-lived effect. So for long-lasting effect, we prescribe lubricating gels. What is the advantage of gels? They have higher strength of viscosity agent. This gel form is having higher strength of viscosity agents. And then other one is the lubricating ointments also available. Some people, old people, cannot put time to time eye drops in the daily 3 or 4 times in the eye. They cannot instill eye drops. So most of the bedridden patients, we prescribe lubricating ointments. And also for bedtime also. Because during bedtime, patient is unable to instill the drops for longer times. So we can give bedtime lubricating ointments. They can be used in the daytime also in severe cases. And slow release ocular inserts. And I already said ocular devices are available to release some drug releasing ocular devices. In this category, we can give slow release ocular inserts. Those are available in the form of cylindrical rods containing 5 milligrams of hydroxypropyl methyl cellulose, and they are inserted in the conjunctival sac. So the patient will get continuously lubrication. Then coming to the intraocular irrigating solution. What are intraocular irrigating solutions? What are the uses of? Anybody have an idea? Anybody? Hello? Nobody is making sound. Am I audible? Am I audible? Hello? Where is the class representative?
Audible.
Then do you have any idea about intraocular irrigating solutions? You don't have?
No, ma'am.
Hanging from over the surgeon's patient's head. What is that? Did you observe that? You didn't observe? Okay, I'll explain. What is the intraocular solution? While doing performing cataract surgeries, to maintain the intraocular tension and to maintain the contour of the globe, because we give incision over the globe. So suppose we do not maintain the globe contour or intraocular tension of the globe, we cannot perform surgery and globe will collapse. To avoid that, we'll give some intraocular irrigating solutions. Okay, that is the use of intraocular irrigating solutions. Then I will tell the functions. That solution should be clear and maintain the moisture of the ocular tissues. While doing the cataract surgery under the microscope, we expose the eye by putting speculum, intraocular speculum. So the patient cannot blink on himself because he is under anesthesia, and we put the ocular speculum. And to facilitate the surgery, the patient should not have any movement. Meanwhile, the cornea may get dry due to absence of blink reflex and tear secretion, blinking. Due to the paralysis, and we retract the lids while doing surgery. So the cornea is directly exposed to the microscope, light of the microscope. And it will get dry immediately. To avoid that drying of the cornea, the assistant surgeon will put continuously the irrigating liquid over the conjunctival sac and cornea. Okay, that irrigating liquid should be clear and maintain the moisture of the ocular tissues, and to maintain the physiological and anatomical integrity. As I said already, they will maintain the physiological and anatomical integrity of the globe and provide cellular nutrients for the functions during prolonged intraocular surgery. These solutions should provide the nutrients to the cornea for functions during prolonged intraocular surgery. Because suppose we left the cornea like that without putting the intraocular any liquid over it, that cornea will dry and that will become hazy. Hazy means the surgeon cannot perform surgery because patient can see, surgeon can see the intraocular structures through the cornea only. Without corneal transference, surgeon cannot do any intraocular procedures. To avoid that, we put in irrigating solutions. Okay, do you understand? Nobody is responding?
Yes, ma'am.
Yes, ma'am.
To avoid that corneal dryness and haziness of the cornea, we'll put continuously the irrigating solutions over the conjunctiva and corneal surface. And intraocularly also we'll irrigate the intraocular remnants of the cataracts, nucleus. After extracting the cataract, the remnants of the cortex and cortical matter should be removed. For that also we use these irrigating liquids. And to maintain the shape of the globe and to maintain the tonicity of the globe. For that, so we use finger lactate solution. Okay. Okay. This will provide the cellular nutrients for the functions during prolonged intraocular surgery and to maintain corneal transparency by maintaining the metabolism and avoiding corneal clouding. Because corneal clouding should be avoided because surgeon can't do any surgery without seeing through the cornea. So corneal clouding should be avoided by putting these irrigating liquids and to maintain the intraocular pressure. Okay. After removal of the intraocular lens, cataract, the intraocular pressure will be lowered suddenly. Then the globe may collapse. To avoid that, we will put irrigating liquids inside the globe. Uses. The main uses of irrigating liquids are during cataract surgery. As I told already, cataract surgery, the main role is after maintaining the corneal integrity and maintaining the tone of the globe is done by the irrigating liquids. And while doing the glaucoma surgeries also. This is also to maintain the chamber and tissue moisture and wash delirious substance. What is the delirious substances? That is nothing but the leftovers of the cortical matter. After extraction of the nucleus of the lens, some cortical remnants will be there. That may produce, suppose you left that cortical matter inside, it may produce after cataract, a patient may not be get vision after post-operatively due to the obstruction of the visual axis by these leftover cortical matter. So it should be removed thoroughly after performing the nucleus extraction. Okay, corneal surgery and anti-segment reconstruction. Corneal surgery also for keeping the cornea moist and keeping the corneal nutrition. For that also we use this irrigating solution. And anti-segment reconstruction means immediately after removing the nucleus from the eye, there will be collapse of the anterior chamber. So the anterior chamber volume will be maintained by putting by giving intraocular solutions. And while doing vitrectomies and postchirurgical, any surgery on the eye, intraocular surgery or extraocular surgery like pterygium extraction or anything, we should use the irrigating solution to keep the cornea moist, cornea and other tissues moist, and maintain their functions, integrity of the cornea. Then what are the commercially available preparations? Intraocular irrigating solutions. First one we commonly used in our practice is Wenger lactate solutions, balanced salt solutions, balanced salt solution plus. That means they have some glucose molecules in that. And first, what is the composition of Wenger lactate? Sodium chlorate 1 or 2 molecules, millimoles, potassium chloride 4 millimolecules, calcium chloride 3, sodium lactate. What is the pH is 7.2, normal pH, human blood pH. Osmolarity is 279. What is the advantage is maintains the integrity of the tissues. Disadvantage is prolonged perfusion causes endothelial cell breakdown and corneal swelling. Postoperatively, suppose you do surgery, prolonged exposure, surgical exposure is there due to some other complication or some surgeon's problem or any surgical problem. The immediate postoperative period, the patient may get corneal edema and defective vision. For that, we should use treat corneal edema accordingly. Suppose the patient is got any postoperative corneal edema, we should treat it with Diamox. And next one is balanced salt solution. This one is composition is millimolecules per liter. Sodium chloride 110, potassium chloride 10, calcium chloride 3, magnesium chloride 1.5, sodium citrate 8, sodium acetate 29. pH is 7.4, same like blood pH. Osmolarity is 305. Advantages is better tolerated irrigant, but it is most costly, it seems, because in government setup we use only Wenger lactate. Disadvantage is less protective than the BSS plus. After prolonged exposure, it may result in polymorphism, stressed endothelial monolayer. That means corneal endothelial layer is only single layer hexagonal cells. Suppose any damage of the corneal endothelial tissue, they cannot regenerate. Instead of regenerating, the remaining cells will expand to cover the defect. You understand? And there may be pleomorphism. Due to the effect of this BSS solution, the cells may undergo various shapes and stressed endothelial monolayer. That means the endothelium breakdown of the endothelial pump, and that will again cause a cloudy cornea, postoperative corneal edema, and patient may get defective vision. So it should be treated postoperative. Then what is the advantage of balanced salt solution plus? Composition in millimolecules per liter. Sodium chloride 122.2, so potassium chloride 5.08, magnesium chloride 0.98, disodium phosphate 2.5, dextrose 5.11. I said already it will contain dextrose. Oxidized glutathione also. This is also additional ingredient when compared to the balanced salt solution. And sodium bicarbonate 25. pH is same as above. Osmolarity is 305. What are the advantages of this BSS plus? This is isoosmotic, corneal endothelial function is maintained even on prolonged use. This is the main advantage of the BSS Plus. Lens clarity is maintained. Blood aqueous barrier is maintained by glutathione, which protects the cells against oxidative stress. So this is more advantageous over all these irrigating intraocular solutions. So it should, whenever we perform cataract surgery and any complicated surgery and then pediatric cataracts also, we should use better to use balanced salt solution plus. And then, sorry, wait, another topic is there. More viscous and elastic. The main advantage of this is it maintains the globe integrity and it is elastic and it aids the the main advantage, it prevents the damage of the intraocular structures with any intraocular instrument. While using before putting any intraocular instrument into the eyeball, before putting the instrument, we'll put the viscoelastic substance. It will act as a lubricant between the tissues and instruments. And while putting the intraocular lenses also, while implanting the intraocular lens, we'll put viscoelastic substance intraocularly, then only we'll put the intraocular lens implantation. Whereas this solution is only to irrigate and aspirate the substances, whereas this viscoelastic is used for each and every procedure intraocularly before putting any instrument intraocularly. They have dual properties, that is viscosity and elasticity. They should be inert. That means it should not cause any reaction intraocularly, and non-toxic. They should not cause any toxicity to the intraglobular structures, any in the ocular structures, and it should be transparent, so that it should aid the surgeon to perform surgery intraocularly. And what is ideal viscoelastic? Chemically, it should be inert, isoosmotic, non-toxic, non-antigenic, and should be sterile. Optically, should be a clear substance, and it is hydrophilic and dilutable. Protection of the corneal endothelium, maintenance of the space. These are main functions of any viscoelastic substance. Before doing any intraocular procedure, we instill the viscoelastic to avoid the trauma to the intraocular structures and mainly to protect the endothelium damage while putting the instruments inside the anterior chamber or while extracting the cataract also. And maintenance of the space also. Immediately after extraction of the nucleus, there will be collapse of the anterior chamber. So immediately after extraction of the nucleus, we will put viscoelastic substance inside the anterior chamber to maintain the globe structure. Suppose the globe collapses, there will be touch of the instruments and endothelium. That will cause the damage of the corneal endothelium. To avoid that, we use viscoelastic substance. There are mainly two types of viscoelastic substances. One is cohesive and other is dispersive. This cohesive type is high viscosity. It adheres to themselves and are used as spacers and for tissue manipulations. For all tissue manipulations, we use this cohesives used for capsulorhexis and IOL implantation. In case of when capsulorhexis is performed while doing phacoemulsification. For doing phacoemulsification, we should use technique of capsulorhexis to remove the part of the anterior part of the lens capsule, and then only we should put, after removing the lens, we can put intraocular lens. The example is sodium hyaluronate. This is a available preparation, common preparation. And dispersive one. What is the dispersive one? Is a low viscosity substance. It adheres easily to external surfaces, protects corneal endothelium in phacoemulsification. It is a combination of chondroitin sulfate 4% and 3% sodium hyaluronate. Whereas cohesive is only sodium hyaluronate. These two types are used in the corneal, intraocular viscoelastic substances. The available preparations are methyl cellulose is the most commonly used one. Its active ingredient is 2% hydroxypropyl methyl cellulose. Sodium hyaluronate is 1%, hypermalose is 2%, and chondroitin sulfate is 20 and 50% is available. This means this is a low viscosity, dispersive viscoelastic. Now, what are the clinical uses? As I told already, while extracting the cataract, with or without IOL implantation. For any surgery over the eye, we need to put viscoelastic substance. This will be used to installation of this viscoelastic substance will maintain the anterior chamber while doing the surgery, and it protects the corneal endothelium from damage from the surgical manipulations. We may unknowingly the surgeon may damage the corneal endothelium. Suppose the instrument is directly we put the instrument that will be it will touch the corneal endothelium. That is enough to damage the corneal endothelium, and visual outcome will be poor. So we should not damage corneal endothelium while doing surgery. To avoid that damage, we use viscoelastic substance. And coating of IOL. For putting the IOL, installation of the intraocular implantation of IOL also, we should use viscoelastic substance, because IOL is a small structure, lens, having optic and two haptics on either side. For easy implantation of the IOL, to facilitate the implantation of the IOL and to avoid the damage to the tissues due to that IOL and instruments, we'll put viscoelastic substance and we'll implant the IOL. Dialing also. After putting the intraocular lens, it should be placed in the correct position by dialing the haptics in the 3 o'clock and 9 o'clock positions. For that, we need to distend the posterior capsule of the bag of the capsular bag. Suppose we do not distend the capsular bag and do IOL dialing, it may damage the posterior capsule and the IOL may drop into the vitreous. To avoid all those complications, we'll put viscoelastics into the posterior bag of the capsule. Then only we'll implant the IOL and dial the IOL. So it will act as a buffer between the tissues and the instrument or IOL. Okay? And to prevent the entry of blood and fluid into the anterior chamber. While doing the surgery, unknowingly we may damage some tissues and some bleeding will be there. Suppose the intraocular bleeding is coming, surgeon cannot see anything and cannot do anything. And cannot extract the lens and cannot see anything. So to avoid that, you can put viscoelastic, because it is a heavy substance. It causes pressure over the iris and the blood vessels, and it will stop bleeding. And so that the surgeon can perform surgery easily. Next, it can also be it is used in glaucoma surgeries, keratoplasties, retinal detachment surgery, repair of the globe in perforating injuries. Any intraocular surgery, we should use viscoelastic to maintain the globe integrity and to protect the tissues. What are the side effects of this viscoelastics? After performing the cataract surgery and all the things are over, after putting the IOL and everything, at the end of surgery, we should irrigate this viscoelastic substance by using ringer lactate or BSS solution. If any, suppose any viscoelastic substance is left over inside the globe, postoperatively there may be rise of intraocular pressure. because this substance is highly viscous and it may block trabecular measure and it will cause rise of intraocular pressure. So after performing the surgery and IOL implantation, we should thoroughly irrigate the viscous substance with ringer lactate. I mean, here we are using only ringer lactate solution. And this is the clinically available form in the market, Viscot. This viscoelastic is injected through the incision or through the side port incision. While doing, this is a picture while doing the cataract extraction in phacoemulsification. This viscoelastic supports the nuclear pieces and prevents vitreous prolapse. In case of while doing the phacoemulsification surgery, type of cataract surgery. And the other one is most important drug is anti-VEGFs. That means anti-vascular endothelial growth factors drugs. And what is VEGF? And vascular endothelial growth factor. This is a group of proteins involved in angiogenesis, lymphogenesis, and vascular permeability. Where do you get this angiogenesis? Anybody?
Tumors.
Huh?
Tumors, ma'am.
Sorry?
Tumors, ma'am.
Before that, most commonly we see in case of diabetic retinopathies, proliferative diabetic retinopathies. That means, what is the difference between proliferative and non-proliferative? Non-proliferative diabetic retinopathy is only due to a longer duration of diabetes. There are changes in the retina. We have cotton wool spots, hard exudates, and microaneurysms. Okay. Whereas proliferative retinopathy means there is, along with that, hard exudates and microaneurysms and venous tortuosity, we will have new vessels, neovascularization. That is called proliferative diabetic retinopathy. In this condition, this proliferative diabetic retinopathy, there will be neovascularization, and that means formation of new vessels, and these new vessels are very fragile, and at any time they may break and cause hemorrhages into the retina, and that will lead to formation of fibrosis and retinal detachment. So, in these conditions, whenever we see this neovascularization, we should treat the patient by using these anti-VEGFs. Anti-VEGFs are a group of proteins involved in angiogenesis, lymphogenesis, and vascular permeability. They are responsible for neovascularization in disorders like whenever there is a hypoxia in the retina, then there will be, it acts as a trigger and it will produce vascular endothelial growth factor that will produce new vessels. This is seen in conditions like age-related macular degeneration, diabetic retinopathy, like that means proliferative diabetic retinopathy, sickle cell retinopathy, neovascular glaucoma, and severe central retinal vein occlusions. And what is the pathogenesis of VEGF in the eye? As I told you already, its triggering factor is hypoxia. There will be accumulation of lipid metabolic byproducts, oxidative stress to the retina and retinal pigment epithelium, alterations in the brush membrane, and in the case of age-related macular degeneration, there will be drusen. Drusen is nothing but due to reduction of the choriocapillaris blood flow and block diffusion of the oxygen and nutrients to the retinal pigment epithelium and photoreceptors. That is called drusen. This is found in ARMD, that means age-related macular degeneration conditions. All these conditions will lead to hypoxia. Pathologically, VEGF-A is secreted by the retinal pigment epithelium. That will lead to formation of new vessels. That is nothing otherwise called neovascularization. And this is a picture showing the production of the vascular endothelial growth factor. This is in the case of age-related macular degeneration. There will be edema, leakage of the proteins, and formation of the abnormal vessels. Next, what are the anti-VEGF drugs we are using in the clinical practice? They are monoclonal antibodies which act against the vascular endothelial growth factor, mainly VEGF-A in the eye. First one is ranibizumab, pegatinib, bevacizumab. This is the flow chart showing hypoxia, VEGF upregulation. Other growth factors also may produce VEGF. These are insulin, IGF-1, FGF-1, PDGF-1. Other one is hyperglycemia, ages, pro-inflammatory cytokines. This will lead to blood retinal barrier breakdown, leading to diabetic macular edema and neovascularization, proliferative diabetic retinopathy. What are the clinically the available preparations? We'll see the doses. Ranibizumab is multiple intravitreal injections in the dose of 0.5 milligrams per 0.05 ml for every 8 weeks in case of proliferative diabetic retinopathy. Mechanism of action is binds to all isoforms of VEGF-A and inhibits their activity. Molecular weight is 48 kD. Trade name is Lucentis. The other one is Macugen. Macugen is nothing but pegatinib, multiple intravitreal injections in the dose of 0.3 milligrams in 90 microliter for every 6 weeks. It should be given every 6 weeks. It binds to 165 isomer of VEGF-A and inhibits its activity. Molecular weight is 50 kD. Trade name is Macugen. Bevacizumab is intravitreal dose is 1.25 milligram is given intravitreally. It binds to all isoforms of VEGF-A and inhibits their activity. 149 kD is the molecular weight. The trade name is Avastin. And these are available anti-VEGF drugs. And these are used to treat in the age-related macular degeneration, diabetic retinopathy of proliferative type, central retinal vein occlusions, neovascular glaucoma, choroidal osteomas, juxtafoveal telangiectasia, retinopathy of prematurity, central serous retinopathy. What are the complications of these VEGF drugs? Cataract formation, glaucoma, vitreous hemorrhage, and by giving the drug, we can may damage and cause damage intraretinal vessels and give rise to vitreous hemorrhage. Suppose we should not take any defective sepsis should be maintained. Suppose it fails, it may end up with endophthalmitis, retinal detachment. While giving the injection, we should be very cautious, and the pressure of the globule should be maintained. Otherwise, it may lead to retinal detachment. And the last one is dyes used in ophthalmology practice. These are mainly used to diagnose. Various dyes available in practice are fluorescent sodium, fluorexone, indocyanine green, rose bengal, lissamine green, tryptophan blue, methylene blue, vertiporfin. Fluorescent drug is most commonly used in the OP basis. This will stain the erosions. Any epithelial defect is stained with fluorescent. It is a water-soluble dibasic acid dye, orange-red in powder form and yellow in solution. This is available in the form of strips. Uses are corneal staining to look for abrasions and ulcers. It is seen in cobalt blue light. And for doing appellation tonometry also, we use fluorescein. And to perform tear film breakup time test. And to this test is performed to rule out the dry eye. And Seidel test. This is performed any leakage of the aqueous post-operatively in shallow anterior chamber after cataract surgery. And then rigid contact lens fitting. Then intravenously fluorescent dye is used to perform fluorescent angiography. Fundus fluorescent angiography. FFA. Fundus fluorescent angiography and iris angiography. And when the cornea looks like this. Suppose any ulcer or any epithelial defect in the cornea, it will be stained with fluorescent fluorescent green, and it is seen like this. Staining of the cornea infiltrate, corneal abrasion, and conjunctival lesions also we can see by staining with fluorescent dye. And the another one is fluoroxone, useful in patients where fluorescence is contraindicated. Patient where contraindicated, suppose the patient is allergic to the fluorescence, we can use this fluoroxone to check the corneal integrity in patients with soft hydrogel contact lens, as it does not stain the lens. Tear film breakup time and applanation tonometry also it can be used. And the other one is indocyanine green. This is highly protein bound and with near infrared fluorescence. So it is used ICG fundus angiography, useful for choroidal vasculature. To see the choroidal vasculature, we use indocyanine green. Instead of using fluorescent green, we use indocyanine green. Mainly for visualizing the choroidal vessels while doing fundus angiography. ICG enhanced the anterior and posterior capsular access in childhood cataracts. And the other one is rose bengal and lissamine green. These are useful in staining dead and degenerative cells of cornea and conjunctiva. They are used to detect ocular surface disorders like dry eyes. Vertiporfin is used in photodynamic therapy. That means in ARMD and choroid neovascular membrane treatment, we use photodynamic therapy, where we can treat the CNVM by using vertiporfin. And these are the clinically available preparations of these dry strips. And this is a picture showing stain with the rose bengal. You can see these pink stains. This rose bengal stain the dead and denuded tissues. In case of dry eye or a passive condition, may affect estimated 11 to 22% of general population. The condition causes burning and stinging of the eyes. And the trypan blue. This trypan blue is used to stain the anterior capsule. To see the anterior capsule clearly before doing capsular access, we use this trypan blue. It is useful in enhancing the anterior capsule, lens capsule visualization before performing capsulotomy in cataract surgeons. Stains the anterior lens capsule without affecting the corneal endothelium. This is the main point to note. Under the complications, sometimes it is used in large quantities, may cause bullous keratopathy. Suppose if it is used in excess quantity, it may cause bullous keratopathy. That means there will be swelling of the edema of the corneal endothelium, corneal epithelial edema also, and cause bullous keratopathy. And this is a trypan blue. While performing cataract surgery, for doing anterior capsular rhexis, for visualizing the capsule, you can use this trypan blue. The anterior capsule of the lens is stained blue so that we can know the capsule properly. You do not stain the inside lens or lens cortex. Okay? For this 1% trypan blue is used. Okay, thank you.